I'll call upon our next speaker, Dr. Ramdip Ray, who is going to present his the paper about vascular anastomosis for the GI surgeon. Welcome, Ramdip.
Thank you. Before starting my presentation, on behalf of many of us at Kolkata, we'd like to welcome many of our colleagues whom we have worked across India. Welcome to Kolkata, and hope you enjoy the food here. My presentation is not for the liver transplant surgeons. It's for the non-transplant surgeons. We will be talking about vascular anastomosis for the GI surgeon. And so this is the kind of potential that a vascular anastomosis has on a really, really bad day, not just in transplant, but in any situation where you need an inflow. This was a case in which no inflow was available. We called the cardiac surgeon, took a radial artery graft, and the surgeon anastomosed the radial artery to the aorta, and we anastomosed it to the graft, to the right artery. And so in a really, really bad situation, this is the importance of vascular surgery. And vascular anastomosis is typically required when you are least prepared. So we need to be prepared always. If you're a transplant surgeon, then the entire transplant thing is your training for GI, because we believe that transplant is basically a vascular subspecialty of GI surgery. It's just operating within the vessels of the HPB or GI system. And there are situations in which you may require, we'll not get into it. This is the situation where we have a right hepatic artery injury in Whipple's, and you may need to do this kind of a repair where the GDA is turned around and used to join it to the right hepatic artery. This is a case where there was an RCC, and very often GI surgeons or transplant surgeons are called in. And what we have done is, it was a very bad thrombus because they had done an arterial embolization beforehand. So everything was stuck to the IVC. So we sort of bypassed before and after, then took out the thrombus, and then finally replaced the IVC first, and then took out the side-to-side bypass that we had created. And this is a graft for Whipple's. I will not go into the details. This is a very nice review article by this lady, which has all the details that anyone can look up. But we are all aware that anastomosis can be by triangulation. Now, conceptually, triangulation is good because you can see the inside better. But you end up having more threads, so chance of your threads getting entangled perhaps a little more. Whereas if you have just a half and half, where you take the corner stitches, then perhaps it's easier to mentally think of the anastomosis, but visualization inside the lumen may be a little difficult unless you have magnification, which is a very, very useful instrument. So anastomosis, mentally you have to picturize, can be either by halving, by taking the two halves, so the corner stitches, or by triangulation, or by a back wall up technique where you sort of join the posterior most stitch first, and then work your way on either side and coming forwards. You choose whichever technique but what is important is you have to go in at 90 degrees. And when we say at 90 degrees, if you look at the picture with the green tick on that side, you have to realize that the needle has to be at 90 degrees throughout its course. And then the thread has to be at 90 degrees throughout its course. Very often the assistant is pulling it in a different direction, as shown in the cross marked. So it's very important that the end of it, it's a hole, not a cut. So we need to plan what kind of anastomosis. And this I have shown so that you have an idea, that we have an idea about how we are going to place the stitches. How they are going to be placed at 8 or 10, whatever you choose, interrupted stitches equidistant from each other. Whenever you do an anastomosis, you will never have a very good video because access is always a problem. The best videos you will always get on the internet, as in this one, from microvascular surgery, because there is a connection to the microscope, not someone actually. So we need to look at microscopic videos, not be intimidated by them, but those microscope videos give us an idea about what is the ideal anastomosis under the maximum possible magnification, which we are trying to achieve. Then you modify it for bigger arteries. So please look at these videos, and then you'll see how they are placed. And then once they're done, you complete one layer, and then you flip and go backwards. And then finally, when you take out the clamps, you always have to take out the distal clamp first, and then the proximal one. This is the principle which we have to follow at any time. Now, I will show you videos mainly from transplant, because the advantage of transplant is it is very photogenic. It is very visually easy to see because they are big incisions. So the basic concept remains that we have to take the corner stitches, and you have to be a little obsessive about placing it at bang opposite ends, because that sort of is the framework on which you are then going to do your remaining suturing. So the corner stitches are very, very, very important. They're important in bowel anastomosis also, but in vascular anastomosis, perhaps it's even more. And in vascular anastomosis, the good thing is that if it doesn't work, if the bleeding happens, it will happen then and there. So it's more gratifying, perhaps. So here, the important thing is you put the corner stitch, secure it, and then from outside, you need to come in. In any vascular anastomosis, in any continuous venous anastomosis, from outside, we have to then take a stitch and come to the inside. And you come inside, and then you now concentrate on the posterior. Now see the discrepancy between the lumen on the left and the lumen on the right is almost 1.5 to 2 times. But it's never a problem so long as the corner stitches are placed properly, and then you plan so that the stitches are equidistant on both sides. And then when you complete, you reach the corner. Reach the corner. Very important that go right to the corner, and then we take the needle outside. All knots at all points of time, without exception, in all vascular anastomosis, have to be outside. Irrespective of whether you're doing the posterior layer, the anterior layer, even if you're repairing a hole in the IVC, which is on the posterior most aspect, at every time, the knots must always be outside. So you secure the corner, and then you turn around and go to the opposite side. Now, portal vein, whether you're doing it for transplant, whether you're doing it for Whipples. Now, very often in portal vein, you find that in a Whipples, you find that there is a kind of biggish involvement, a larger area of the portal vein involved. And very often we think, okay, let me just transect the entire portal vein. But the orientation of the portal vein is very, very, very important. And portal vein being a low flow system, any kinking gives rise to thrombus formation. So the angle, it's very important that we get the proper orientation. Here you see we're doing the opposite side, and it's very important to keep flushing the inside for any clots. Any clots can be the nidus for further thrombus formation. And then you pull the thread on one side, make it taut so that you get the opposite side. Now here, if you see, as I try to get the stitch right bang on the opposite side, there is a bit of one side is not really opposed closely, and it's perhaps not right the opposite, because the two lips should be really flat and should be touching each other. So we take out the stitch and then put a fresh one. And once we have put this fresh one in the right place, you will see that the two lips are completely opposed and parallel to each other, and then we move on to taking the stitch on the opposite side. When you tie the first knot, you're on the outside, then you need to come in on the inside. This is true of any IVC repair, any portal vein repair, the same thing, and it's best to use a similar technique which you can replicate again and again rather than having different kinds of techniques for different situations. Now here you see, I'm on the anterior layer, and as you see on the anterior layer, there is an eversion of the lower side or the proximal side of the portal vein. And as I keep stitching, the eversion sort of becomes more prominent. You'll see on the next stitch. And instead of trying to correct the eversion, I would rather have it everted even more. So here you see I evert it even more, place the knots on the inside, because the objectives are two. One, that there has to be endothelium to endothelium apposition, so the intima are in touch with each other, and also any extra portal vein length is not desirable. And here you see the final bit, and we are taking out the corner stitch. You see there are 4 threads, 2 are going to come out, and just the 2 threads going to remain. And then when we tie, we are going to tie it not on the wall, but at some distance, at least 1/3, typically much more, away. So that's how we incorporate what is called a growth factor. And it doesn't bleed, provided you have gone right to the end. And you see here, this is the growth factor. And the growth factor was actually first described by Thomas Tarsal, one of the main, the pioneers of liver transplantation. And the idea being that there is extra thread needed as the wall grows in circumference. So you have to make allowance for that portal vein to grow. And this is what happens. You see the portal vein. We will now release the clamp, about to release the clamp. And you will see the portal vein caliber filling up. And it will fill up much more as it accommodates more blood. It's always nice to see others' complications. I shall show you a nice right hepatic artery injury here. We have confirmed that it's a cystic artery, and then we are dividing it. And as we are dividing it, we see there's a bit of a bleed. We think it's pericholedocal, but then we are not so sure. And then finally we realize that it's not. It is either a posterior or a main right hepatic artery to be confirmed on. And then we identify the stump. This is where we identify the remaining stump. I'll finish very quickly. And dissect it carefully. Try to identify whether it's a big artery, whether it needs repair. Ideally, always should be repaired. And once we have done that, we'll now put the clamp. And once the clamp is, the bulldog is put there, you will see that the lumen is visible. So that's the lumen. And then that's the repaired artery. We don't have a video of that particular artery because we were not in the mood to take a video. But in general, this is what is done, where the artery is prepared. And once the recipient artery, inflow artery is prepared, and this is the artery, and we'll check which artery to use as inflow. That could be one, or we could use the other. And this is an arterial anastomosis being done. Very short video.
Yeah, thank you, Ramdip.
Yeah,
the time is up.
And I will complete by, I think we finish up, I think. This is just a portal vein where you first apply the clamp on the wrong side, wrong orientation. Then again you turn it because it has to be the right side. So the orientation of the portal vein clamps right from the beginning have to be very important. And I will finish by saying that we have to practice, if you're not transplant surgeons, on humans as surrogates where you're doing a pancreatic duct anastomosis. That can be your practice ground. And if you're nothing else, and if you don't have major issues in getting these, you can actually practice. This is a goat liver, and they have excellent veins which can be used to practice. This is one such goat liver in which it has been practiced. And so in some way or the other, GI surgeons doing complicated GI and HPB surgery need to be trained in this particular technique. Thank you very much.
Thank you very much, Ramdip. Excellent demonstration of the vascular anastomosis in the field of GI surgery. And I don't know, how often do you come across in Whipples or pancreatic head cancers doing a venous anastomosis?
Portal vein reconstruction.
Yeah, portal vein reconstruction.
Very often, at least, I think every 6 or 7 Whipples we do, we end up in some form of repair, but very often it's a side wall, or it's a repair which can primarily be closed, but yeah, sometimes even complete. Yeah.
Any question from the floor?
Dr. Ramdip, could you possibly discuss the ways and means of lengthening the portal vein? Should the resected specimen be such that you can't bring the ends together without tension?
Yeah, so for Whipples or for any HPV surgery, we generally mobilize it as we would do for a liver transplant. So the liver is completely mobilized. That's number one. And that helps because when there is a problem, at that time if you start mobilizing, it becomes a bit of a pain. Second is that complete cauterization and probably mobilization of the intestine and the colon completely. And then you will probably get enough length. And if you have freed it completely from all other structures. And some people even say that you almost always get away without any interposition graft.
Yes, Professor. Yes, Professor Nandi.
If the right hepatic artery is cut and distal to the hepatic artery proper, and you get good backflow, do you have to reconstruct it?
Very often.
You've got good pulsatile backflow with intra-liver anastomosis from the left. You always have to reconstruct the right hepatic artery. They say only 15% of them have necrosis because 85% of them are okay. Do you always reconstruct?
We always try to reconstruct, but whenever there is a pulsatile flow, there's a good backflow, we understand that it's probably okay to get away with it, not do it, but we at least find that is the best possible way to keep practicing one's vascular skills, and 15% theoretically, if it's a problem, then it's a problem. Worst case, it will get blocked. So
yeah,
I would.
You know, we have all these patients who had lap cholecystectomy and injury to the bile duct.
Yeah.
Then some people say you must always do a CT angio, but I can't see why, because if the patient is okay and only jaundiced and the liver flow is okay, why do a CT angio? You're not going to reconstruct the right hepatic artery. Do you reconstruct after injury to the right hepatic artery outside?
In Whipples, we understand that it's okay to not do it.
Lap chole injury to the bile duct.
Yeah.
And you get inadvertent ligation of the right hepatic artery. What do you do then?
If I were to do it and if I could repair it, I would repair it. But I understand that it is okay not to do it, and large majority will have no complications at all. The only thing I would do different than, back in Whipples, is that if there's a right hepatic artery injury, I would do the biliary anastomosis much, much, much higher than probably in any other Whipples to be sure about the vascular supply. That's all.
Would you do a CT angio before every reconstruction on bile duct injury?
For all bile duct injuries referred to us early, we would definitely do a CT angio.
CT angio?
Yes.
So can I answer that as well in continuity? Because the reason, one of the major reasons why we do a CT angio is more medico-legal actually. Because your injury to the right hepatic artery can be blamed that if you go in and operate and you are doing a bile duct repair, it can always be blamed that you who have injured the artery and not the primary surgery. So one of the major reason for a CT angio is this. Second is you'll have a roadmap when you are going and trying to dissect off the bile duct. if you know the anatomy of the right hepatic artery, where is it exactly, you may be able to be safer when you are dissecting out, because that area is obviously very well compromised. There is good amount of sepsis. These patients come with bacterial infection, sometimes pus collections, and you may not be able to suture it at the given time. The tissues may be very much friable. You may not be able to identify the right hepatic artery. So these are the couple of reasons in my mind that as a surgeon, if such a patient comes to us, we would definitely do a CT angio.
Agreed.
Yeah? And in the Whipples, yes, it's very unlikely that you have a pulsatile backflow, because left to right shunt is not always present. If you are able to do a good reconstruction on table, you should always attempt a good reconstruction on table. If you are not able to do it, then well, you will have to accept the fate and move on.
I'm a bit.
You agree with that?
I agree or don't agree. I agree on the fact that we would reconstruct it, but I think our experience is different. That more often than not, we do find a flow.
But you still go ahead.
But we still go ahead and repair it.
Go ahead and reconstruct.
We would reconstruct,
so as a surgeon,
because worst case it will get blocked.
Exactly. So as a surgeon, you're still worried not to reconstruct a right hepatic artery.
The only one where we did not reconstruct there was a good flow. And in spite of mobilizing GDA, I could not get enough length.
So the reason is probably you were not able to.
Yeah, that's all.
Dr. Ramdip, nice presentation.
Thank you, Sandip.
Thank you. So my question is very precise. In a Whipple which is involving, in a pancreatic cancer involving splenoportal junction, how do you deal with splenic vein?
We can do it in any way. In the one picture that I showed, we can tie off the splenic vein, which is described, and otherwise if you can have a inflow above or below, but you're perfectly okay to tie it as well.
So most of the time you will just tie off the splenic vein and just do a SMV to portal vein reconstruction, that's it?
If we are having to replace a significant length, only then.
In case you have a situation where the spinoportal confluence is involved in the setting of a Whipples, it is better that if you have the IMV draining into the spinning vein, if that is patent, then you can just ligate the spinning vein and get away with it, do an end-to-end anastomosis, that's fine. If you're not, and you feel that the spleen is getting significantly congested, you can actually turn it around and anastomose it to the renal vein like a Warren shunt. So that also can be done.
So what we do actually, like if the coronary vein is patent, and it is proximal to the anastomosis, then you are absolutely safe, like the stomach is not getting congested at all. But in a situation often you can see that the stomach getting very congested, and that situation often becomes difficult, you have to reimplant or do something.
Thank you very much. There was a bit of time, since we started early. So there are a couple of minutes time for any further questions. But I would like to raise a question, Ramdip. If you have an accessory right for the donor,
okay,
right? So what do? Where do you anastomosis the accessory right to the recipient?
Okay, so we are talking about a living donor liver transplant where
Yes.
the donor has an accessory right. So, the two situations. One is we are looking at there is an existing right and an accessory right artery.
Yeah.
So that means two arteries to reconstruct.
Yeah.
Whereas, or it's a completely replaced
No,
one.
not in
If
the
it's
recipient.
replaced, it's not an
Recipient
issue.
is one
in
artery.
Donor, if there
In
is
the donor
if donor
liver,
there are two arteries.
two arteries, yeah.
Then we would, and that is a situation very often that is faced, that we have to join it to two arteries. So that can be to the left hepatic and the right hepatic arteries. That can be to the left hepatic or to the GDA, so of the recipient.
Right.
The left hepatic
Recipient's
artery,
left hepatic artery.
left hepatic artery and right hepatic artery. That would be the most common situation.
Right.
And because
No, I'm talking about the accessory on the donor,
yes,
donor
so
liver.
in the donor liver, there would be two arteries.
Yes.
So the accessory would typically be joined to the recipient right hepatic artery, and the original common one, that would be to the left
To
hepatic
the
valve.
left hepatic. Okay, okay.
That's the most common situation, but there are other variations possible as well.
Thank you.